All right, perfect. Go ahead, sir.
Perfect. No, just clarifying that you guys are working with Jane, and disc pathology is your differential.
Yes, that's correct.
Perfect. So how can I help?
Yeah, so I guess I know we weren't really given a lot of information even on the case. I guess our first question is, do you feel like that is a proper diagnosis just given that small amount of information that we can kind of build a case on?
Yeah, absolutely. I mean, I think obviously it's very general. And I think depending on how you develop your impairments and patient presentation, absolutely disc is appropriate as one of those.
Okay. Yeah, awesome. I think I guess what I could do really quick is, so like I was looking at impairments, and if we go over that, if you see any red flags or any additional information based on your clinical experience, that would be amazing to add in. So obviously more of this kind of hip / glute pain, and we were going to use the numeric pain rating scale with that. I think with lumbar spine motions, range of motions, we're going to see a decrease in lumbar extension. That will probably be painful as she goes back into extension, and then obviously more of the right-sided lateral flexion, because I feel like she'd be compressing the protrusion of the disc. So I feel like those were kind of more, and then with hip-related dysfunction that we might see would be more.
Real quick, I'll just stop you for the lumbar.
Yeah.
So traditionally, when we think of disc, what motion is most provocative?
Lumbar flexion.
Yeah, flexion.
Flexion, right. So I think that's one thing from a phrasing when you think about like what's limited, right? If flexion is going to be provocative, I would expect them to have limitation of flexion, whether that's from pain versus, you know what I mean?
Okay.
And similarly with side bending and rotation, typically rotation is one with patients I work with that bothers them a lot. To your point about you're closing out that space and compressing. But thinking about when we think of the spine, right, what area is compressing and where may that be potentially pushing that disc? I think it's absolutely possible for extension to bother them if we think about it, depending on how severe the protrusion is, right? Could they be actually pinching the protrusion as they go into extension? Or is there also like facet dysfunction that's often associated with it? But just being aware of that as you go through as well.
Okay, that's super helpful. Thank you. And then we were thinking about actually, do you want to ask about the special test or the straight leg raise, Vince, that you?
Yeah. So Sarah, we were so I was thinking of doing, during my physical exam, I was thinking of doing some functional tests. So I was thinking of doing squatting and sit to stand. I was doing a little bit of research, and I saw that there is a straight leg raise test, and there's also a cross straight leg raise test. Are those two tests that you would use if you had a patient that had this type of presentation?
Absolutely. And I think that's one of those tests that traditionally helps you rule in, rule out a disc, or can be added to that. So do you know the difference between those two tests?
I think I looked at that in terms of specificity and sensitivity. I forgot which, but I know that one of them is more specific, and whatever that one isn't, the other one is. I forgot which, but I looked at it earlier. Yeah.
So typically you may also hear it as Wells straight leg raise. But basically one is the same sided leg. So say the protrusions to the left, if I raise my left leg, I would have a recreation of my symptoms with that leg. Right. Or let me rephrase. If I'm complaining of symptoms in my right side, so this patient, when I raise my right leg, if that's positive, that's the classic straight leg raise. Whereas if I raise the other leg and it's positive, so raising my left leg recreates my right-sided symptoms, that's considered a Wells straight leg raise, or the cross test.
Gotcha. And then building off that, are there any other tests and measures that you would use in addition to those that would kind of help tease out any type of discogenic issue?
Yeah, so a big one I would look at is just when we think of the TVC, that repeat motion, so centralization, peripheralization. So with lumbar flexion, right, you expect that to be painful, but then more specifically, if they repeat that motion, so say they do it 5 times, with neurologic pain or disc pain, I would expect it to centralize or peripheralize. So for that pain to move, right? As I continue to aggravate that nerve, does the pain get worse? Does it change in some way? As opposed to, say, it's a like muscle tightness, right? That pain's probably going to feel the same every single time.
Okay.
So that's another big one I use to differentiate.
Gotcha. Okay. Thank you. And then actually you mentioned the TBC, and Nicole, she actually, we had that question as well. So Nicole, take it away.
Yeah, I guess looking at the TBC, which kind of category do you feel like she might fit into? Because I know it's hard with limited information that we have. So, you know, I know that I think the increase of like in more of an acute increase of onset within like I think 16 days, and we're at 2.5 weeks. So I feel like that's really close. So which part? And I know obviously it can be an integration sometimes, possibly both. Which ones would you use?
Yeah, so I think absolutely there's a lot of crossover. Pretty much with every patient I've had, they fall into more than one. What I will question you back with is if you're treating it as disc, which one would you expect that to fall in as the primary treatment category? So if disc is a true pain generator.
I believe that I would go off of the I have them right here. I feel like I would want to do specific exercise with possible manipulation.
Yeah. So I agree. Disc will typically fall in the specific exercise category. With that, absolutely, do they have instability? I would bet my money that yes, they do, and that potentially could they need a manipulation? Yes. The thing I would hesitate with that is if this is an acute situation, like it's a quick acute flare up and suddenly they're having this really sharp pain, right? Quickly manipulating those when that area is already inflamed may only cause more inflammation and more pain during that phase. Absolutely, I think manipulation are helpful in patients that have herniated discs more chronically. And can you have facet dysfunction? Absolutely. I think when we think about what the true pain generator is that protrusion back on the nerve acutely. Those quick motions in that position may just irritate the patient more than the reward.
Okay. So start with more of a specific exercises, and then maybe in our notes put if symptoms continue to arise and this turns into more of a chronic issue, go down more of a manipulation aspect.
Right. And I think it's something I think very rare. Like I've never seen a situation where manipulation is by itself. Like you only do a manipulation, great, bye. And I think you're doing a disservice to the patient if you're right. Because how did they get in that position in the first place? So I think as you're going through, right, as you normally would, reassessing, if suddenly you're noting that they're having a set restriction with that, that's where I would bring in the manipulation as you're addressing those movement dysfunctions, that type of thing.
Okay. Yeah, I think that's great. I guess one other thing too, what are kind of more of your go-to manual therapy techniques that you might integrate? Obviously divided or, away from manipulation or grade 5s.
So with a disc specific patient?
Mm-hmm.
So I think for me, it's going to really depend on how the patient presents. So with this case, as you're developing, right, if you want to use some manual therapy, what is the specific impairment that's present that makes you want to do that? Because there's been patients I've had who have acute disc and, every muscle around it goes into spasm and everything's tight. So then, yes, is the disc the true pain generator? Absolutely. But could this muscle spasm also be contributing to their pain? In which case, right, that's why I'm choosing to do a manual therapy. Depends on the location for me a little bit more on what I'm choosing to do and also patient preference, right? Some hate cupping and freaks them out. They don't like it at all. So, okay, we're not going to do cupping. And then I've had others who love it. So I think with that, my goal is typically with manual therapy, especially in a disc patient who may be more acute or struggling, is sometimes just that hands-on can relieve some of that pain. So my follow-up question for you guys with that is what, from a patient-centered approach, is going to be your direction of treatment, right? Because when we think of disc, there's certain best practices for acute flare-up treatment. Do you think this patient has an acute flare of the disc, or do you think it's more of a potentially more aggravation, re-aggravation. And then from her life standpoint, her job involves her being in positions that are uncomfortable. She's working out every morning, right? There's all these other factors. So how are you addressing those in your treatment plan?
So I think one thing that we were discussing was we were kind of going on a back and forth between what our working diagnosis would be in the first place. Originally, we were thinking of sciatica, but my thought process was, okay, sciatica seems to be more of an effect as opposed to a cause in this case, or just in general. So we were thinking, okay, there's this discrimination going on. If we were to be treating this individual, the thing that stuck me the most was that she works 60 hours a week. And I don't know if it's fair for us to, and we don't know like other values outside of that. Like her social history says she's married, she has 2 kids. We don't know to what extent she needs to work. We were thinking, okay, she has a GED, but she's not college educated. So to that respect, it may be difficult for her to have to adjust the amount of hours that she works because they may be providing some sorts of income to her family that they need. But in that regard, I was like, okay, maybe she can modify the way that she works out because it doesn't say anything about how she works out. Is she deadlifting 500 pounds? Is she running on treadmill for 10 minutes at 3.0 speed? Stuff like that. And
Absolutely.
I think
I was just gonna say, I think that's a really good point, right? And when you say disc too, is this degenerative disc disease? Is this an acute protrusion, right? Is this something she had happen back in high school and now is just re-aggravating because suddenly she's working 60 hours and has to squat and sit and she doesn't have good movement mechanics and she's placing more stress on that area. So it's just more of a irritation of that area over 2 weeks as opposed to that true acute flare up where you're not going to look more like an injection, right? Is this something that you need heavy medication versus not? And I think your point about like lifestyle, and that is a huge step of, right, she may not be able to alternate how it works. So what can we do from an education standpoint or discussion to help while she's at work with some of her symptoms? And then from a lift standpoint, what is she doing working out? Is she doing RDLs and in terrible form where she places all her stress straight on her back and she just started doing that 2.5 weeks ago? Right? It may be an easier fix versus she does every movement perfectly, which I highly doubt. But I think in developing like your impairments and what you're finding, noting that in the initial like encounter with her and how you develop your plan around that and highlighting some of those lifestyle components is going to be huge.
Right. Okay. And I think just a super quick question too. The case mentions that chief complaint is that right hip and glute discomfort from radiating pain into the lower back. Is there any significance the fact that the pain is radiating to the back as opposed to from the back? And if so, what is it?
Yeah, so I think in general, yes. And then again, the word choice of radiating versus referred versus whatever, and that's where with the assignment, I'm unsure how black and white it's supposed to be for you guys, right? Is it truly radiating pain, or is it a patient that came in and said, hey, yeah, and the pain radiates to my back? In which case, is it just general achy pain she has up in her back? Is it like a sharp shooting pain? In general, when we think of pain that starts low and goes up, that's where I typically will think a little bit more SI pelvic cause, as opposed to if it starts up and goes down, I'll think more starting at the spine. But there's lots of exceptions I can think of, right? I've had patients come in who only are complaining of hip pain, and the hip is what's bothering them. But then when you go through your exam and you're asking them questions and follow up about their back, they're saying, oh, well, no, it actually hurts more in my back. Right. So this may be a patient who's really complaining about their back, like their low hip area, and that's where they're having a lot of issue. But as you go through an exam and you dig a little deeper, well, oh yeah, I've always had back pain for the last 20 years. I don't like, of course it's normal for me. I don't think anything, but my hip is what's bothering me now. Right.
Yeah. I think that's kind of where the lack of an ability to actually do an actual physical exam, and there wasn't any like objective stuff like at all, like in the paragraph. So we were kind of making up numbers and seeing stuff that would be consistent with that. And that was.
Yeah. So I think my understanding of the assignment is for you guys, right? If you have the disc presentation, determining what you would expect in the exam for your findings. So what impairments are you expecting to find on the exam? And then how are you going to treat those impairments? and how are you relating it back to the patient and making sure it's still patient-centered? Because obviously we're going to treat this patient different from how I would a 19-year-old Division I soccer player.
Sure.
Right.
Thanks for that. Nicole, you got anything else?
No, I don't think so. I was just going to say, going off the patient-centered care, I feel like when I was kind of looking at specific kind of exercises and things like that, I was really going to try to focus on the very first, week of really trying to decrease the pain of the referred radicular pain that you might be having that we're not too sure of. And that might be even like posture awareness, like how to squat with her child, how to squat down to the floor, how to get on her knees, like how to tie her shoes, like things that are, or how to bend over when she's giving her 3-year-old a bath, like things like that might be going into the case, and then really then working on more functional movements like specific RDLs and things like that. That was kind of
Absolutely. So I have to run because our 15 minutes is up, but I agree with you. And I think that patient focus on her life is a huge step. So I think that's awesome.
Okay.
All right. Nice to meet you guys.
Take care. Thank you.
Bye.
Let me stop my